This lecture will cover chest pain and acute coronary syndrome. I know that you've already covered these topics in prior lectures, so hopefully this will be more of a review. However, this lecture will focus more on the inpatient workup and treatment of these conditions. So let me ask you, if you saw a patient in the emergency department or the inpatient setting with chest pain or acute coronary syndrome, would you know what to do? Would you know how to work it up and how to treat it? Well, this lecture should answer some of those questions. Here are the learning objectives for this lecture. As mentioned, this lecture should cover topics you've already learned. However, if something is not quite clear, you can always go back to prior lectures to review them. The recommended reading for this lecture is available online in Access Medicine through the Ruth Lilly Library. The book is called Principles and Practice of Hospital Medicine, and it's a pretty good resource on inpatient medicine. So, just to begin, I'm sure you already know that there are many causes of chest pain out there. Many of these causes are not even cardiogenic, which is what we typically think of with chest pain. It is very easy to be tricked into thinking that chest pain is due to one cause when it is actually due to something else. I've learned over time to question everything. Don't just assume that someone else's history and physical exam are correct. Evaluate it for yourself. Keep an open mind and keep a wide differential in your brain. With this said, I would recommend that you have some sort of document on your phone to review prior to seeing a patient with chest pain. For instance, this is a page from Pocket Medicine that I took a picture of and kept in my phone. When I first started in inpatient medicine, I would spend a few minutes before I went in the room just reviewing the differential diagnosis of chest pain, so everything was fresh in my head and I would keep an open mind when I evaluated the patient. There are 5 can't-miss diagnoses when it comes to chest pain. These include aortic dissection, ST elevation MI, pulmonary embolism, pneumothorax, and esophageal rupture. Now, most of the time, these have already been ruled out in the emergency department. However, mistakes do happen, so you should always keep them in the back of your mind. If you're not sure how to diagnose, work up, or treat these conditions, please review prior lectures, up to date, or whatever your preferred resource is. The first step in determining the workup for chest pain is to determine what should be done inpatient versus what can be done outpatient. This is where you'll utilize those scoring systems that I like to keep in my peripheral brain. Obviously, I don't have all of these scoring systems memorized, and you'll see from the future slides that I wouldn't expect you to memorize them either. However, I do have MedCalc or other apps that easily calculate these. If you don't have an app like that, I would highly suggest that you get that before you start clinicals. Next, you're going to determine what workup you're actually going to do. For instance, is the chest pain cardiac? So are you going to pursue an ischemic workup? Is it more GI related, where you might consider consulting a gastroenterologist for EGD? Is it more pulmonary, where you might consider further imaging of the chest? Or is it musculoskeletal, where you might try different pain medications to see if it resolves their symptoms? The HEART score is a very common scoring system for patients presenting to the emergency department with chest pain. By assigning 2 points towards the patient's history, EKG abnormalities, age, risk factors, and troponin measurement, patients receive a score on a scale of 0 to 10. The HEART score has been validated in several studies and is proven to be powerful, easy, and above all practical instrument to separate patients into a low, medium, and high risk groups. With the HEART score, it is immediately clear which patient is eligible for discharge without additional tests or emergency invasive procedures. Patients scoring 0 to 3 have a 1.6% chance of major adverse cardiac event, or MACE, and can typically be discharged home. However, a score of 4 or higher has a much higher MACE risk and should be admitted for further testing. For pneumonia, there is the CURB 65 score, which assigns a point to confusion, BUN, respiratory rate, blood pressure, and age greater than 65 to determine a score which you can help determine whether the patient should be admitted or if they can go home. A score of 2 or greater indicates that the patient should be admitted for treatment. Whereas the Pneumonia Severity Index is used to risk stratify the patient to determine overall mortality risk in adults with community-acquired pneumonia. Obviously, this scoring system is more difficult to utilize, but is also likely more accurate. For pulmonary embolism, the Wells score evaluates the pretest probability of PE to determine if you should even work it up, for instance, getting a D-dimer or a CTA of the chest. It is validated in both the ED and inpatient settings and typically used in conjunction with the D-dimer to evaluate PE and determine if you should get a CTA. Hopefully, it will reduce the number of CTAs in low-risk PE patients. Wells score can be used with either 3 tiers, low, moderate, or high, or 2 tiers, unlikely and likely. Usually, we just use the 2-tier model. Wells is often criticized for having a subjective criterion in it. For instance, the second point here is alternative diagnosis less likely than PE. Just remember, Wells is not meant to diagnose PE, but to guide workup by predicting pre-test probability of PE and appropriately testing to rule out the diagnosis. Here are some tips for you to help you on rotation. First, don't document it unless you plan to rule it out. For instance, if the patient's history is consistent with a GI cause and Wells score is low, why would you check a D-dimer, which could be elevated in a number of different scenarios other than PE? I used to do this all the time when I documented chest pain as a diagnosis. I would say possible causes include acute coronary syndrome, PE, GI bleed, etc. However, I've learned that a differential diagnosis is for you. It's not for the note. Let's say you put this wide differential diagnosis, including PE, in your H&P and the patient is sent home the next day after chest pain was discovered to be due to GERD. Then the patient presents a week later to the ED and is found to have a PE. Since PE was not ruled out during the initial assessment, the physician or PA could be sued. I'm not saying to never use a differential diagnosis. I'm just saying to only include a differential diagnosis that you plan to rule out. Next, so with this said, have a plan in place. If you say that a patient could have a PE, you need to document and prove why you think this. For instance, you may say the patient's Wells score is elevated and a D-dimer is pending. If this is elevated, we will obtain a CTA of the chest to rule out PE. Next, make sure that you utilize those scoring systems. Document the scores in your impression and plan. They will save you a lot of unnecessary workup and potential legal ramifications down the road. If the patient's chest pain is believed to be GI related, ask yourself, is the patient stable or unstable? Are they bleeding? Is their airway, breathing, and circulation stable? Are their vital signs stable? Do they need a PPI? If so, do you give it IV or PO? Do they need octreotide, for instance, if they're an alcoholic and suspect variceal bleeding? Do they need serial hemoglobins if they are actively bleeding? Do you need a gastroenterologist consulted? Do you need them now or can it wait until later? If the chest pain is thought to be of pulmonary origin, you should consider infectious, inflammatory, restrictive, and obstructive disorders. The question is what diagnostics are necessary to verify the cause. For instance, if the chest x-ray is abnormal, you should consider further CT imaging to determine the cause. Should you get a D-dimer to evaluate for VTE, a procalcitonin to evaluate for lower respiratory tract infection, sputum and blood cultures to evaluate for infectious etiologies, inflammatory markers like sed rate and CRP to evaluate for pulmonary fibrosis or other causes of inflammation. Should you seek expert opinion from a pulmonologist? This is typically warranted if you're not able to confirm the diagnosis or you find a specific condition that will warrant expert follow-up. Musculoskeletal chest pain is often a diagnosis of exclusion. However, it doesn't mean that you can't suspect it as a primary culprit. Obviously, musculoskeletal chest pain is not a medical emergency and should be further evaluated as an outpatient. However, oftentimes chest pain of a dangerous or emergent cause can also be present with musculoskeletal chest pain. As for your write-up, you might say, I feel the pain is musculoskeletal due to, let's say, costochondritis. However, we still need to rule out cardiogenic causes. If the chest pain is completely reproducible on palpation, does the patient have any recent trauma to warrant a CAT scan to evaluate for fracture? Should you trial different treatments like scheduled NSAIDs or Tylenol? Perhaps a Lidoderm patch on the point tenderness might help. Cardiogenic chest pain is obviously very important on the inpatient setting and is one of the more common diagnoses leading to lawsuits, so you should always consider it. First, you should consider if the chest pain is anginal. This means the chest pain is due to a reduced blood flow to the myocardium. Angina is further classified into typical, atypical, and nonspecific. The three classical criteria for angina are substernal chest pain provoked by exertion or stress, and chest pain that is relieved by rest or nitro. If all three of these are present, it is considered typical angina. If two out of three are present, it's considered atypical. If only one are present, then it's considered nonspecific. Therefore, a patient who presents with chest pain that is fully reproducible on palpation and believed to be musculoskeletal may still warrant an inpatient cardiac workup if the pain is also, let's say, substernal or gets better with rest. After you've ruled out the type of angina, you should rule out acute coronary syndrome. As you should already know, there are three types of acute coronary syndrome: unstable angina, non-ST elevation MI, and ST elevation MI. One way to break this down is either ST elevation acute coronary syndrome, otherwise known as STEMI, or non-ST elevation acute coronary syndrome, which is further broken down into unstable angina and NSTEMI. STEMIs are so important to differentiate because they should go for immediate angiogram. However, with unstable angina and NSTEMI, you typically have some time to burn to further investigate for other causes. NSTEMI and unstable angina can be very difficult to differentiate. Therefore, the treatment is typically the same for both of these diagnoses. NSTEMI and unstable angina are differentiated based on the presence of myocardial necrosis, otherwise an elevated troponin. Obviously, NSTEMIs will have an elevated troponin and unstable angina will not. However, per the Fourth Universal Definition of MI in 2018, an NSTEMI also requires new horizontal or downsloping ST depression greater than or equal to 0.5 millimeters in two contiguous leads, and or T-wave inversion greater than 1 millimeter in two contiguous leads with prominent R-wave on ECG. This becomes a little confusing though when you have a patient with a normal EKG but elevated troponin. With this said, you should remember that not every elevated troponin is an NSTEMI. When in doubt, you should always consider acute coronary syndrome as the culprit. However, if the patient doesn't have any anginal symptoms but does have an elevated troponin, you may consider several other conditions listed here. This is why a review of previous records, including previous troponin levels, a thorough history, and perhaps expert opinion from a cardiologist may be warranted. Consider a patient with hypertensive emergency. If a patient has persistently high blood pressures, it can squeeze down on the arteries in the heart and cause a troponin leak, but will usually improve once the blood pressure is lowered. Or a patient with end-stage renal disease. They will typically have a chronically elevated troponin, which is typically due to decreased clearance of troponin by the kidneys and unrecognized heart failure. Another way to think about it is by MI types. There are 5 types of MI, but type 1 and 2 are by far the most common. Type 1 is a spontaneous myocardial infarction caused by atherothrombotic coronary artery disease, and is what we classically define as acute coronary syndrome. Type 2 is an MI due to ischemic imbalance due to a condition other than coronary disruption. For instance, if the patient has any of the causes on the previous slide, it is typically considered a type 2 MI. Once again, you should have a low threshold for calling a patient a type 2 MI. These patients should still have serial troponins, EKGs, and perhaps an echocardiogram to further characterize the cause. A type 3 MI is a myocardial infarction resulting in death when biomarker values are unavailable. A type 4 MI is a troponin elevation seen after PCI, and a type 5 MI is a troponin leak after CABG. After ACS is ruled out and angina is further described, you should make sure that the heart score has been calculated to determine if the chest pain should be evaluated inpatient or if it's safe to discharge the patient for outpatient workup. After this, you should get serial troponins, which are typically done at 0, 3, and 6 hours. When determining this, you should always consider when the chest pain started. For instance, if the chest pain began at 4 a.m. and the patient presented to the ED at 11 a.m., if the initial troponin is negative, you likely don't need to further trend the troponin. Now, this is one of those things that is textbook medicine, but usually not real life. You will usually see that most providers also trend at least 2 troponins. Also, I was always taught the rule of 4s when it comes to troponins. It first elevates at 4 hours, peaks at 44 hours, and can remain elevated for 14 days. You always need to place the patient on telemetry to rule out any underlying arrhythmias that could be the culprit of their pain. The next step is to determine the most appropriate stress test. At bigger teaching hospitals, you will typically have a cardiology consult on these patients to help determine the most appropriate test. However, at smaller centers like my hospital, the hospitalist team determines the stress test. Stress tests may seem confusing, however, there are just a few simple rules you should remember, and this will actually be fairly simple. Stress tests are divided into 2 simple questions. How are you going to stress the patient, and how are you going to test the patient? You stress the patient via exercise or medications. Obviously, exercise is the best because you get to see how functional the patient actually is. If exercise is used, you can test the patient via EKG, stress echo, or nuclear stress. Exercise EKG is usually done for low-risk patients and typically done more on the outpatient setting, as these patients usually have low heart scores. Exercise echocardiogram is done by getting resting echo images and comparing them to images done after exertion on a treadmill. The cardiologist will then compare resting and stress images to determine if there are any wall motion abnormalities. This test is optimal if you also want to look at the patient's ejection fraction or if you hear a murmur on exam that you might want to further evaluate. However, this test should not be done if the patient has a pacemaker, coronary artery disease, or a left bundle branch block, as these can cause false positive left ventricular anteroseptal defects. You should also consider if the patient will have good cardiac windows, which may make it difficult to determine on physical exam alone. But consider, does the patient have COPD, where the lungs may make it difficult to determine stress images by echo? Or do they have large breasts that may make it difficult to obtain accurate images? If exercise cannot be used, a medication-induced stress test should be done. This can also be performed by stress echocardiogram with dobutamine, which is basically liquid exercise, as it is both inotropic and chronotropic. As with exercise, you shouldn't do this if the patient has a pacemaker, coronary artery disease, or a left bundle branch block. A nuclear stress test is performed using a vasodilator. There are 3 types of vasodilators used, including adenosine, dipyridamole, and regadenoson, also known as Lexiscan. Regadenoson is the primary vasodilator used because it has the lowest risk of bronchospasm. This is an important concept to remember because if you are evaluating chest pain in a patient with COPD exacerbation, remember that you could significantly worsen their condition by doing this stress test. Therefore, it may be more beneficial to treat the COPD exacerbation first, then after a few days consider the nuclear stress test. Now, vasodilators stress the heart a little differently than other forms of stress tests. Basically, you take resting nuclear images, then you give the vasodilator and take further nuclear images. The key to understand is that vasodilators will dilate the coronaries. However, stenosed arteries will not dilate very much at all. Therefore, the normal arteries will steal blood away from the stenotic coronaries, which will cause a perfusion defect on nuclear images. Overall, nuclear stress tests and stress echoes have about the same specificity. However, sensitivity is a little lower with echoes. But nuclear stress tests also involve giving nuclear contrast, which sounds more scary than it really is, and are also more expensive. Finally, at large institutions, CTA and cardiac MRI are occasionally utilized. These are very sensitive and specific, but are not widely available and are very costly. I know that probably seemed a little confusing, but let's break down a few sample cases for you. Let's say you have a 38-year-old African American female with a history of hypertension, non-insulin dependent diabetes mellitus type 2, hip dysplasia, and smoking history who is admitted for chest pain and has negative serial troponins. What stress test would you do? Please feel free to stop the video if you want to think about this. So you may consider EKG stress testing. However, this patient has hip dysplasia and may not be able to walk briskly enough to get the desired heart rate. With this said, I would probably order a dobutamine stress echo. However, take into account if the patient has large breasts or COPD from smoking, as big lungs and breasts may diminish cardiac windows. Next example, you have a 72-year-old white male with a history of coronary artery disease, hypertension, hyperlipidemia, insulin-dependent diabetes mellitus type 2, and osteoarthritis, admitted for COPD exacerbation and chest pain rule-out. Serial troponins are negative. What stress test would you do? So I would probably go with a Lexiscan. Since the patient has coronary artery disease, you should not do an echo stress test. With his osteoarthritis, age, and COPD, I doubt he will be able to perform a treadmill testing. However, remember that a Lexiscan uses regadenoson, which is a vasodilator, which can cause bronchospasm. Therefore, you want his COPD exacerbation to be well treated before pursuing stress testing. And finally, you have a 43-year-old white female with a history of hypothyroidism admitted for chest pain and syncope. EKG is unremarkable. Echocardiogram revealed an ejection fraction greater than 55% and diastolic dysfunction grade 1 and positive for regional wall motion abnormalities. Initial troponin was negative, but the second and third set were slightly elevated. What stress test would you get? So this is actually a trick question. This patient has positive markers, so I would highly consider that the patient has an NSTEMI. Stressing this patient would be a good way to induce an MI. This patient would be best treated by cardiology consult. Then if they felt stress testing was warranted, you could proceed. Now I'll take just a few minutes to discuss acute coronary syndrome workup and treatment. The TIMI score is not a score used specifically for chest pain, but rather for patients already diagnosed with acute coronary syndrome. It basically predicts their mortality risk and provides a basis for therapeutic decision-making. Acute coronary syndrome treatment seems cumbersome, but is fairly straightforward. First, you need to consult cardiology for further expert opinion. Next, you should proceed with specific treatments. Now previously, MONA-B was the treatment of choice. However, newer guidelines have changed to the thrombin's S2 mnemonic, which I hope is what you have learned in your cardiology lectures. Thrombin's 2 begins with thienopyridines, which include either Effient or Plavix. Now, all textbooks will tell you that it is important to add thienopyridines or a P2Y12 inhibitor like Brilinta. However, clinically, this is a little more complicated. Think about what these agents are going to do. They permanently block platelet aggregation, making the patient at increased risk of bleeding. So if the patient undergoes a left heart cath and is determined to need CABG, you are going to have to wait 5 days before you can do surgery. Therefore, it is usually recommended that this decision come from the cardiologist rather than the internist. Next is heparin or low molecular weight heparin, which I'll discuss shortly. Next is the renin-angiotensin system, which includes starting an ACE inhibitor or ARB, which will help prevent remodeling. These are particularly beneficial in anterior MIs. Also, don't forget, ACE inhibitors cause a cough, whereas ARBs don't. Next is oxygen. Oxygen should be used only if the patient is hypoxic. Next is morphine. which actually has no proven improvement in outcomes that I've read about, but it is still used quite frequently. Next is beta blockers, which should be given within 24 hours as long as the patient doesn't have any heart failure, shock, or heart block. Remember, these are negative inotropes, so if the patient is fluid overloaded, it will decrease contraction, which will worsen the patient's heart failure. Next is interventions. I will discuss these shortly. Next is nitro, which is a vasodilator which decreases preload, therefore reducing ventricular wall tension. Remember that you will get hypotension if nitro is used with erectile dysfunction drugs like Viagra, Levitra, or Cialis. Also, nitro should be avoided if a right-sided infarct is suspected. You will usually know this right away because the patient's blood pressure will quickly drop. And last but not least are statins and salicylates. Aspirin should be given as soon as possible. As a note, the statin dose should be decreased if the patient is greater than 75 years old. Next, I'll talk about anticoagulants. The primary anticoagulants include heparin and Lovenox. You really don't need to memorize this, but heparin is dosed at 60 units per kilogram as a bolus, followed by 12 units per kilogram, then further adjusted based off their APTT. Lovenox is dosed at 1 milligram per kilogram BID. Now, deciding which one to do is a good question. You need to consider what the patient's bleeding risk is. If the bleeding risk is high, Lovenox should be fine. If the bleeding risk is low, Lovenox should be fine. However, if it is high, heparin should be utilized. Next, I'll discuss interventions. So, a left heart cath, also known as an angiogram, is done to view the blood vessels. Balloon angioplasty carries approximately 30 to 50% restenosis rate in 6 months and is typically reserved for stenosis of small blood vessels not amicable to stents. Drug-eluting stents are the most commonly used stents and have drugs in them to decrease neointimal hyperplasia, which is the number one cause of in-stent thrombosis. This is around 5% for drug-eluting stents, whereas it is closer to 25% for bare metal stents. These stents require dual antiplatelet therapy for at least 1 year, so if the patient is very non-compliant, a higher bleeding risk, or has expected surgery within 1 year, the stent may not be the best. Next is bare metal stents. These stents don't have any drugs in them. These only require dual antiplatelet therapy for 1 month, but as mentioned, carry a higher risk of neointimal hyperplasia, which can lead to further in-stent stenosis. As a practice point, if someone were to ask you right now, what's the difference between anticoagulants and platelets, could you answer them? I've had a lot of clinical year students get hung up on this detail, so I just want to clarify it. Both of these drugs are used to treat Virchow's triad, which describes how a thrombus forms. Anticoagulants treat venous stasis, whereas antiplatelets treat endothelial damage. So think about it. If you have a patient with a DVT or PE, you would treat with an anticoagulant because venous stasis is what led to the thromboembolism. If a patient has coronary artery disease, then they have endothelial damage to the blood vessel. Therefore, you need to prevent platelets from sticking together on the arterial wall. Now, if you have a patient with acute coronary syndrome, you have both endothelial damage and venous stasis. Remember, the coronaries are called arteries, but they really are veins as they carry blood to the heart. Therefore, initially, you should treat with both antiplatelets and anticoagulants. That's why you see aspirin and anticoagulants as the treatment of choice in the thrombin S2 mnemonic. So on my final slide, I just want to review a few uncommon practice conundrums that you could see. Let's say you have a patient on warfarin or a direct oral anticoagulant, formerly known as NOACs, who present with acute coronary syndrome. How do you anticoagulate this patient? Well, the general rule of thumb is to hold the home anticoagulant and begin Lovenox or heparin. However, oftentimes I consult a cardiologist to help in this decision making. Now, let's say you have a patient with a history of GI bleeds who presents with acute coronary syndrome. What do? Well, you need to ask yourself, what is going to kill the patient first, the MI or a potential GI bleed? Typically, you will begin heparin or Lovenox because you can you will begin heparin over Lovenox because you can reverse it, whereas Lovenox, it is much more difficult. With this said, you would then closely monitor the hemoglobin for changes, and if necessary, get cardiology involved as soon as possible to expedite an angiogram if warranted. Here are my resources. Please feel free to post any questions you have to the Google document. Thank you.